our esteemed panelists today. Dr. Adnan Munkarah, he is the Executive Vice President and Chief Clinical Officer of Health. He is a board-certified gynecological oncologist with an incredible career as a clinician, a researcher, an educator. He is a professor of obstetrics and gynecology at Wayne State University. He's authored more than 165 articles and book chapters. He served as a visiting professor, invited lecturer nationally and internationally, and he's held so many board positions and recognitions. I think we'd be here all day if I was to list off the seats. So it's in the pen, but please read off the brochure. And Dr. Munkarah, thank you so much for joining us today. I guess to get us started, you're a very high-level healthcare administrator, and you're also a physician with a very established career. And so to start us off, can you please speak to us about the physician role in healthcare administration, and how can physicians steer healthcare in the right direction?
So, can you hear me? Wow. Yes. Okay. So, first, my thoughts and advice is that before a physician thinks about saying they want to be in administration, a physician needs to be a physician, and they need to be a good physician first. And I'm seeing a lot of young people who are wanting to be physicians, who go to medical school and they say, we're not going to practice because I want to be vice president, and I want to be this, and I want to be that. And I don't think, in my opinion, this is the right path. In order for somebody to get into administration, it is not worth for them to go for 7 years and 8 years of education and another 3 to 6 or 8 years of training to say what I'm going to do immediately going into administration to do that. Now, on the other hand, I strongly believe that physicians need to be involved in administration. But administration is not also for everyone. And I have a lot of great and very accomplished colleagues who are brilliant, who are excellent clinicians, who are excellent leaders in the field, who do not want to be in administration. There are few who are interested to go into administration, and administration is really a stretchable kind of and a very wide spectrum that you are looking at. Because you can be in administration running a clinic, you can be in administration running a division, you can be in administration running a department, you can be in administration being a dean of a school, you can be in administration being a dean of a hospital. So it is important for us to kind of discuss what we are thinking of in that respect with respect to administration. The reason I believe physicians have a mandate to be involved in administration is that as we look at healthcare at the present time, our healthcare system is broken. And the reason I say our healthcare system is broken is that our healthcare cost at the present time is 18% of our GDP. This is higher, almost 80% higher than the next second country behind us. And our clinical outcomes do not speak for that cost that we are paying. And I think part of it is the fact that physicians have not been involved closely in administration in the past. And this is why I really believe that physicians need to be part of the solution in the future rather than part of the problem.
And so, I guess what is the progression from physician to administration? Is there an actual progression? It seems to be there's many paths. So can you speak on that?
So again, my bias and my inclination that when somebody finishes medical school and finishes their residency training, they need to practice medicine. They need to be trusted physicians in their field among their colleagues. And their trust is earned by doing what you do best, what you study for most, whatever specialty you are in, whether you are connecting directly with patients or interacting with patients. People need to know you as a competent physician before you can start saying, well, I want to get into administration. Otherwise, it is a pity for people to spend so many years of their lives studying medicine, not practicing, medicine. Now, once you get into that, then you make a determination whether this is something that you want to do. Because in administration, it involves a lot of things that are not things that, as you go to medical school, are things that you look forward to. I'm thinking in the clinic, anytime seeing patients, than spending hours of my day in administration in meetings. But the reality in administration, this is what you need to do, spending your many hours of your day being in meetings in that respect. And this is why it's important to determine whether this is something that you are interested to do, and this is something that you're not. I enjoy it. I enjoy the method. Having created a career that I have had to, and I think that I'm blessed to do that. But it is not for everyone. And this is why it's important for people to determine where they want. Let's assume that somebody is interested in administration. As you said, there are different paths. So for me, that path before was, after I became a faculty, I became a division director. So I was leading the division of gynecologic oncology and administrating the division of gynecologic oncology in addition to being a physician at that time. Then, I became the chairman of the department. So I was leading the chairman of the department. Then I got elected to be on the board of directors of a large medical group, the Harrisburg Health Medical Group, which is over 1,500 physicians. And I was on the board, and I chaired the board. I acted in my work as a chief medical officer. During this time, it has been an evolving learning. And there are a lot of things that even late in my career I had to learn that I was not exposed to before, which is the business of medicine. How do you sit down and talk with your colleague in administration? How do you understand the financial statement? Things that you don't take in medical school. And these are things that you need to learn in order for you to be a successful administrator, like there are things you learn to be a successful physician.
How do you think being a physician has informed your decisions in healthcare administration? Do you see a difference between physician leaders and just healthcare administrators?
So, to me, as a physician, usually bring to the table the view of the clinical practice that they have been in. Whether it is, again, indirect patient care or indirect patient care. And what I mean by indirect patient care, there are practices where you are directly dealing with patients. There are practices, pathology, radiology, some of the pharmacy is not a physician, but in the PharmD, where they sometimes are not directly interacting with patients, but they are still in clinical practice, they are impacting the clinical care. So when you are practicing as a physician, there are certain things that, again, in addition to the credibility and trust that you build with the team that you are working on with your colleagues, there's also something that you start understanding what are the problems that your colleagues and your team is feeling on a day-to-day basis. So when you are in an administration role, you understand what people have lived through and what people are going through. So if you think about it, if you are a physician and you have had to use an electronic medical record, it is you understand what might be the pains of using an electronic medical record. These are the things. If you are a physician and had to use technology that's really related to pathology or radiology, you understand what might be the pain and the challenges you have. So when you become an administrative leader, these are things that you have lived through and you are willing to tackle and sometimes prioritize. And if you do not have that challenge or that experience, you might not be paying attention to. When you are a physician and you are dealing with patients, you understand what care experience is about. It is not anymore just an aspect, it's something objective, complete that you live with. So this is where you can kind of add to the value of having lived through the shoes of the people that you are.
So more broadly, what would you say are the necessary skills or characteristics for someone in administration?
So I really think that the skills that you need in administration, because when we talk about administration, I'm assuming you talk about administration leadership. Yes. To me, the attributes of the leader are the same attributes whether you are a physician or non-physician. A leader is there to serve, and the higher your leadership role is, your role becomes more and more to facilitate things for the people you work with, to serve the people you work with, rather than just be the person who you think of to make a decision every single day. I can tell you that 99% of the time when decisions need to be made, it is for me to facilitate and for the team to make that. It is not for me to make those decisions. And the higher responsibility is, the more you know that you need to kind of have the right team around you, and make sure that you support the right team around you, and serve the right team around you. And this is what people talk about servant leadership. Servant leadership means your ability to facilitate what the team does on a day-to-day basis. What you can do is advise people. I also, from the first day of my practice, I saw myself, even when I was in junior faculty at that time, having my training, I felt at that time that I had to be a leader in my team. I needed to work with my medical assistants, with my nurses, with the rest of the team, with the secretary, even if I did not have any title. I was just the first year of my practice. And the leadership is to be there to kind of help people, help them make the decisions that they need to take care, that we take care of the patients that we need to. And these are the things that we need to aspire to. There is a talk that I used to give we have the Physician Leadership Institute, and the Physician Leadership Institute is an institute where we train physicians into administration and management and what other things that we talk about. And I used to kind of share with people that the old formula that you have to become a physician leader, or what you need to do, you go through medical school, you do your training, you start practicing, you write papers, you start academically long, and then you become a leader, are gone. Because the reality today, academic success is important, but it's not sufficient to make you a leader in the current healthcare environment.
So I guess touching on this Leadership Institute, here we have a lot of very ambitious students with us here today. And so what advice would you give to them? What are these opportunities they can seek out to develop these leadership skills and these experiences they can have to give them a better perspective?
So what you're doing today is preparing for that leadership. You're sitting here together today and having this discussion is part of preparing for leadership. Whether you are a student, a medical student, or a resident, as you are starting to sit together and develop and work together, this is what leadership is about. Leadership is about team building. Leadership is making sure that you are driving whatever project you are working on as a team, and making sure that you understand how you complement each other in that respect. The academic stuff, the clinical stuff, you are going to read it in the books. But this is why most of you at the present time, the way you are learning, they push you to work together as a team. And you cannot become a successful leader unless you are a successful team player. Unless you are able to kind of build the things together and work together and being able to advance things. I really strongly believe that leadership is not a title. People can be leaders without having a title. And most people who feel that they are leaders without having a title succeed over the years because they take that responsibility and love. So continue to do what you're doing. You are doing here. That there are that you're having, working together and making sure that you invest what you need to invest. My question to you, when you are done with this, is to say, what did we do this conference about and what we are trying to achieve? What is the difference that we can make with healthcare? Many of you are aspiring medical students or minor medical students for it. To see what difference I'm going to make. And what difference I'm going to make as an individual, as part of the team, not as an individual to see whether I'm going to be a successful writer and just do academia, so that I have 200 papers or 50 papers.
Thank you. That's very insightful and inspiring. I want to talk a bit about your personal experiences. Do you feel that you reached the position you're in as a natural evolution, or as a series of intentional choices, or maybe a combination of both?
I do not believe that anything comes as a natural evolution that you don't work. It is important for us to thrive. You need to drive success. We have a great opportunity. We are living in a nation. I grew up in Lebanon. I grew up in the middle of a civil war. I do not have the opportunity that many of you and my children have at the present time, which is great. I'm glad that we are all here. We are able to create that opportunity. When I applied for application to come here for residency, there was no main in Lebanon. I mean, we had in the middle of the civil war, and there was no postal service. So we needed to kind of find a good kind of different path to kind of send our applications come in here. When I first came here to the States, I needed to find a place to stay initially. The first week of my residency, I was staying in a hospital room that was on the floor that's vacated because we had not rented an apartment yet because we did not know that we need to rent an apartment. So these are things that in life you can work for things to drive that. I started internal medicine I did not get into obstetrics and gynecology initially because it's a competitive specialty, and although I came from a good school and had good grades, but for that they had a lot of competition. And I spent 2 years doing internal medicine before I applied to obstetrics and gynecology. So the reason I'm sharing these with you, I know many people have had, I look at work with you on much more cheap than I haven't learned at your age. So all of you are very highly cheap and very well delivered. But my advice to you is to continue doing what you're doing. Because life, you have great opportunities in this country, you have great opportunities what you are facing at the present time. By learning more, I strongly believe that you'll be able to kind of capture the opportunities that exist out there for you.
So speaking about these different things within your life, not only are you a leader in healthcare, but you're also a very accomplished scientist and clinician, as we discussed earlier. So those of us interested in this career path, what is it that you miss?
So going back to what I was talking about before, when I finished medical school and I went to residency, my goal was never to be I never aspired to be in the position that I am at the present time. What I wanted to do, I wanted to be a great clinician, deliver the best care, the specialty that I wanted to do, and I wanted to find solutions for the problem. So that is that we work together with other teams, talk about teamwork. Some of the first work we started doing in research, clinical research, where your wonderful colleagues has been a partner research for me, is try to understand what are the things in ovarian cancer that we might be able to kind of change so that we improve this progressive ovarian cancer. Because I was seeing these patients of mine who are coming in with AWPs, 7-8 hour surgery on them with their chemotherapy, and they are fine for some period of time and they come back. So my work at that time with many of my colleagues at that time and partners in research is to see what solutions can we find at that time and provide better care for our patients. And as we built that up, and we started doing that up, and opportunities started coming my way, I started understanding that individually I can make less of a difference, collectively the difference becomes much bigger. So we started looking to see, okay, now beyond an individual person doing research, how can we have multiple people have a bigger division that's interested in treating and managing ovarian cancer? How can we collaborate with people around the nation to kind of do that, internationally do that? And at one time, when I was doing these things, I was doing it to say, okay, it's another checkbox for me, so that I can take another kind of higher position in that respect. So when I became chairman, I looked at my job to kind of make sure that the department I'm in is the best department that I can make at that time. And this was my focus at that time, to make sure that why we make it the best department, so that we can provide the best care. So these things are things that have driven me, and this is one that I accomplished when I had started having these things done. And with the opportunities that were created, people said, okay, can you take that, can you do that work at that time? And there are times when you take risks. It is take risks meaning people give you an opportunity, although you might not be comfortable with it, but you say it can make a difference. This is what you're going to kind of say, I'm willing to do it, and understanding that I might not succeed in. If every single opportunity that you take to succeed in, this means you will not take enough risks. There are times that we need to take risks and fail, but what's most important by failing is to step up and have lessons learned, so that you succeed in the next endeavor that you do.
So teamwork and collaboration definitely seems to be a very big theme here. And I'm wondering, do you have any advice for creating connections, maintaining those connections, and just working with others? How's that something that we can develop now?
So networking is extremely important, and getting to know people and work with them is extremely important. And that going back to what we talked about leadership, leadership and decision making. A lot of times, if you have a project that you are working on, or if there are things you are doing, together. So we are preparing for the conference. The ability to kind of sit down together and make a collective decision is extremely important. And the ability to create a team that does that over and over and over again is extremely important. Listen to people, make sure that everybody's voice is heard. Is important. Continue to connect with people who sometimes you might not be comfortable connecting with. It is very easy as a human being for us to kind of go into the direction of the easiest path for us. People who kind of speak our language, people who kind of feel comfortable with us, people who have the same cultural values that we have, which is great, but it does not help when you are looking at diversity. It is in diversity that is strength. And then diversity needs to be at different levels. So as you are building networking, I would suggest that you can go beyond the areas that you are comfortable with. The other thing is take goals and put goals for yourself. There are aspirations and challenging. Again, going back to that concept, everything I do, I succeed at. This means I have not challenged myself enough. I need to kind of challenge myself.
I want to transition to your time as a clinician, specifically in the Middle East. You've worked as a clinician in Arab countries and also as a clinician here. And many of our audience members, they have families and parents who need care and assistance here. And, I think it would be very interesting to learn from you, being exposed to so many different scenarios, the differences between the two, and the physician-patient interaction here versus the Middle East, and, with Arab Americans and the American system. So I'd love to hear about your experiences in this regard.
So, talking about taking risks and complete experiences, I think my experience in the Middle East was, again, taking a risk, one of the most humbling and learning experiences that I had in my life. Because at that time, I was 7th year. My path was kind of paid for me. I was writing papers, I was serving on compassionate societies, and I was enjoying my life. I had a position that stayed at that time. Part of my decision to move to the Middle East at that time was driven by family decision. I wanted my children to be exposed to the culture, to be close to home. And at multiple occasions, people have come to us, have said, you want to move back at that time to Lebanon, to Beirut, and I considered that the situation there was not the best. And then, opportunity opened for me to go to Saudi Arabia. So, talking over with my wife, and we got the opportunity and said, we'll go there and do it. And, here I am, again, I thought, well, this is the perfect match. Here you have someone who has grown up in the region there, who speaks the language, understand, understand the culture, the religion. I'm going to be there, we're going to have the resources, and everything is going to kind of work well. So we moved there, and I came with the prospect that then being younger and not having that children, I would say, here I am, very well achieved, high, multiple applications, and everybody in the department that I went to Saudi Arabia to be Faisal Specialist Hospital in Riyadh, which is one of the biggest hospitals to essentially run the department of women's health, obstetrics, and gynecology. And I thought that with coming there and going to tell people, this is what we're going to do, and everyone going to listen. Wrong. The first few months that I was there, so Thursday, Friday was the holiday day. The system there is a very rigid system. So they have what they call the consultant, which is the senior staff, and then you have the assistant consultant, which are people who have trained but have not done fellowship, have not been to the Western world, and have to do these things, and then you have something that residents. I can remember for the life of me, I was used here that over the weekend, we go and count on our patients, so as the husband, what we need to do. So here after the weekend, and I said, okay, you are going to kind of algebraic report, so we had 4 gynecologic oncologists, and we had a busy service there in that clinic. That we are going to start looking on our patients. And the most senior person there, who is local, national, has been there for a while, said, no, I don't come on the weekend. I said, well, I'm the chairman, I'm telling you that you can come. I said, no, I'm not coming. not come. And it was the culture. And it was not, there was nothing that I was going to do. That's what the guy changed his mind. But what I started doing, I started coming around with myself. And I would run with the resident, and I would run around with the assistant consultants. So this is one of the things where you learn, you think you can work as a leader. Is to me, if I had to do it again, I would want to set up a room and say, how do you think is the best way for us to cover the relationship with the weekend? The other thing that I've learned is that, unfortunately, as great medicine and medical sciences are in this country, we have some level of arrogance for those of us who have trained here. I have trained at MD Henderson, cancer center, one of the best places in the world to have cancer training, and we think that there is only one way to do things. And when you go over there, there are people who have trained in great places in Canada, in Germany, in France. They bring a different perspective. And being open to listen to that perspective is extremely important. The third thing that was very also humbling is that I saw diseases there and she took care of people that had only read about in the book. So there are things that are prevalent there, and some of the severity of the illnesses that I've done there, I've never seen it here. And I had to have to practice and do it. And the fourth thing I've learned that is gratitude. People are extremely grateful to what you are doing. So I had a lot of things that really helped me in my life, my career, that opened my eyes when I went there. And this is an experience where initially it started as a family and personal experience, but turned out to be a really great growing experience.
Yeah, thank you so much for sharing. It's very inspiring. I want to bring it back to the present day. Right now, you're very involved in decision making when it comes to healthcare delivery. You're meetings in the current decision, current conditions, and also future conditions. So I guess a little bit speculative, but where do you see us going in the future regarding healthcare delivery at the individual level, with doctors and providers, and also at the macro level with hospital systems?
So I'm going to be provocative as I talk, but I want to preface by saying is while healthcare and medicine are changing significantly, and there are significant challenges ahead of us, in my mind there is no better time in history to be in the medical field for those who are interested in it. And the reason I'm saying that is that those who decide to go after a medical career or who are already on that path will be able to change the future of healthcare. I talked to you about the challenge that we have today. Our healthcare system at the present time is not sustainable. We cannot continue to spend 18% of our GDP on the healthcare system. We cannot continue to have some of the highest mortality related to maternal mortality and infant mortality when you compare to other industrialized countries. It is not acceptable. However, we have at our hand a lot of things that will be available to us to make that difference. And this is why I'm saying, this is why, to me, I got into the job that I want to get to as much as I was taking care of patients, because I do believe that we can make a difference. And I'm going to take it in a number of kind of, I would say, items or topics. First, talking about the customer and the consumer. And I'm talking specifically about that. There are a lot of my colleague physicians who object to that and say we talk not to forget the patient. The patient today is a customer, is a consumer. The patient today does not want to be living what they lived in the past and even up to now. I can tell you when I started my practice, a great physician was seen as a physician who would take 3 months to see them. If you go to that clinic, you are looking 3 hours to be seen by that physician. I don't think this is right. I don't think this is acceptable. I think we as physicians, as a medical profession, have created that legacy in the past and we want to change it. Because people do not want to wait 3 hours to be seen irrespective of what we have. There are better ways of doing it. And we are going to have a competition, and we do have a competition today for people saying we do not accept what we have at the present time. So that consumer mentality is rapidly getting into healthcare, and we need to know how to fix it. The second is related to science and technology. Technology is advancing so fast at the present time. I have no doubt in my mind that all of us sitting in this room will probably, whether we like it or not, will have our genomic profiling in our medical records in the next 5 to 10 years. It is what will happen. We might not know all the implications and what this indicates for us, but there's a huge amount of data. Data is connected at the present time and will continue to be connected with wearables. What's going on with electronic medical records is going to be impressive. And when you add to that artificial intelligence and machine learning, we are going to be at a point that we've never been in medicine before. The amount of data that we need to analyze and predict how we can intervene, when we can intervene early, what medication works better, which cancer I can cure and which cancer we cannot cure, and what are the options of using that therapy. The third is related to care model and the workforce. We anticipate a physician shortage as well as a nursing shortage. We are living in nursing shortage today, and it is very challenging. And we anticipate a physician shortage coming up and continue to escalate over the next many years. Going back to teams, medicine is a team sport. When we were learning medicine, we learned it as an individual player. And we have learned that this is not the recipe for success for healthcare. What I mean by medicine is a team sport. That needs to include not only the physician, but it include a physician, a nurse, a histopathology technician, a radiology technician, will include a medical assistant, will include all of members of the team to be able to drive what we need to drive and improve the healthcare. And we are going to use technology to help us advance that teamwork and come together. This is why a lot of curricula at the present time that are happening in medical schools, they are looking at interprofessional learning. How do you get the teams to start working and interacting together? Things that we've not done in the past. In the past, medical students are sitting here, nursing students are sitting here, social work is sitting here. The reality is that 70% of the outcome of a condition, a healthcare condition, is impacted by things that are not within the hand of the physician. It is related to social determinants. Whether we have access to specific food, or to medicine, or to transportation, or to the appropriate housing, or to the lifestyle. And this is why how we think about care models, they are going to be important in the future. Economy. We are moving, because of what I've talked about with respect to the cost of healthcare, what we are doing is we are moving from a fee-for-service medicine to what's called value-based care. And I want to kind of spend a couple of minutes because probably, if not all of you, most of you do not understand what is called by value-based care. So how we used to get paid for care in medicine in the past was a transaction-based payment. This means if a patient comes to see me, I kind of put a certain diagnosis on the medical record at the time. I send it to the insurance or the federal government, and I get paid for that specific diagnosis. The problem that it has created by doing these transactions, it kind of, to some extent, encourages people to over-utilization of certain things without understanding the implications of the cost of care. So let's say if we have somebody who has hypertension and we put them on certain medicine. If I bring that patient every week to see me, I'm getting every single week to see that patient. Irrespective of whether their visit with me added value to controlling their blood pressure or not. So you can have a patient seeing a physician 7 times a year for hypertension without knowing the diagnosis of the doctor 7 times a year and have to pay for the visit 7 times a year. With value-based care, what's happening now, the payers, the insurance, the federal government are going to say, this is not acceptable to us. What we want to do is manage you as a in medicine, in medical profession, healthcare, based on the outcome giving, not based on the transaction you are doing. So rather than having and treating an individual person on a transaction basis, what I was saying, you have a population that you are treating. This is what we sometimes talk about population health, population medicine. And what this means, there are thousands of people that you are treating in your system going forward. And these 1,000 people, I expect to spend so much on them, and I expect you to have these outcomes on them. So if I have 1,000 persons that I'm treating, I want you to tell me, and there are out of the 1,000 people, 20% have hypertension. Tell me how many of these people who have hypertension have controlled hypertension today. If you hit the target that we are talking about, I'm going to pay you what you deserve for the 1,000 patients. If not, you are going to take a haircut. If you do better, you are going to get an incentive. So with very basic care, what we are looking at is how to manage the whole population of patients rather than individual patient. And this is what people are pushing for more and more at the present time, to kind of understand how to drive the cost of healthcare. How many of you are seeing commercials on TV now related to Medicare Advantage? Can I have a show of hands? How many of you have seen these commercials on TV? You see priority or others talk about Medicare Advantage? Don't be nervous. You can, it's okay. So many of us, do you know what Medicare Advantage is? Show of hands. Okay. So Medicare, essentially what we are, Medicare Advantage is that kind of migration from the government, the federal government from CMS, how we advantage basically. With Medicare Advantage, what we are saying, as a government, they don't want to kind of be sitting and paying physicians on an individual basis. What we are doing is, they are taking the money, contracting with insurance companies, the Blue Cross of the world, the Health Alliance Plan, the Priority, the United, and saying, these are the population that you are managing, and pay you that much per person, and then you work with the provider are the physicians, the hospitals who can drive what you want to drive into the future, and you can decide with those providers, how much it's costing to take care of these patients. So we are going to see more and more of this, and we are going to see more and more of the focus in the future on value-based care, which takes us to the next item, which is related to how to manage and how to function in the future. A few years ago, I think 2 or 3 years ago, was the first year where the percentage of employed physicians in the United States have surpassed the percentage of independent physicians. And that trend is going to continue. And this is based on the Medical Association studies. And that trend is going to continue in the future. It's going to continue in the future because it is impossible for individual practitioners to be able to kind of have all the infrastructure in the future to manage patients and the population levels. There are a lot of information that needs to be driven from that. There is a lot of infrastructure that needs to be built in addition to the private medical records. So we are going to see that migration more and more from independent physician practices to bigger practices. Even private practices need to get bigger and bigger physician organizations to be able to manage what needs to happen in the future. Some people look at that as a negative. And I don't think honestly it's a negative thing. There is nothing negative about working in teams and working in groups. You don't need to be employed. You can still have some independence and autonomy, but working as teams and groups becomes extremely important in the future as we are looking at. And the last thing that we need to kind of be thinking of is that life work balance. Most of you probably, if not all of you, have much better appreciation of the need to balance your life than most of us in our generation have had. And it is not healthy and it is not right. And that life-work balance is extremely important for the future. For your future, for the future of your children, for the future of your grandchildren. And to me, this is going to drive us more and more again how we work teamwork, how we work as teams, how it's not only me who can kind of, it's only me who can do that procedure, it's only me who can see the patient, it's only me who can take care of the patient over the weekend, it's only me who needs to be here so I cannot take vacation. We need to work as a team of physicians, team of providers and supporting providers in order for us to drive the future. So this is why going back, despite the challenges that are happening at the present time, I would not call them challenges, I would call them opportunities. I really think this is an exciting time for us to be in medicine because we can make a difference, we can prove the change. I really believe that in the United States we have the best medical sciences in the world. If you look at medical sciences, research, technology, whether we are looking at investments in biotechnology or we are looking at investments in medical devices, this is the place to be. This is the country to be. However, we have one of the most broken healthcare systems in the advanced world. And to me, we either can complain about it or we can be part of the solution because we have the resources, we have the smart people who are sitting here together, and we need to be part of the solution rather than continue to be part of the problem.
Do you have any advice for us to prepare for this future? Is there any fields of study that we should try to pursue? Is there any skills or habits that we should pick up as we prepare for this exciting future?
Going back to what I talked about before, now you know the facts. My advice to you is go and read more about it. And as you go into medicine because of your love of the field of medicine, whatever practice you are in, but go into medicine with the concept that I'm going into medicine because I know there is a patient I need to treat, but there is also a community that I need to rapidly help you. It is not only the individual patient who's walking into my clinic, but it is the community that's around me. How can I, as a healthcare professional, make a difference in the health of the community? Because again, going to the point that I've said before, at the end of the day, that 18% of healthcare, we are paying for it today. Those of you who are already working and have taxes being kind of deducted of your paychecks are paying for it. And you're going to continue to pay for it for yourself and for your children. So until we decide that we are going to bring that down and have a better healthcare system, we are going to be all feeling the pain of that. So this is my advice as you are thinking to go into medicine. Again, I love medicine. I will never do anything different. I will never take it as different from what I've done before. I will never go back to the administration of a medical school. I love taking care of patients, and I miss taking care of patients today. But what I love today is that because I'm taking care of patients, I identify the problem, that exists collectively, that I'm able to kind of work with great teams, clinicians, non-clinicians, administrators to be part of the solution. So my advice as you go into this, step back and look at the forest. Don't get lost among the trees.